All right, this is Dr. Steve Kahn, and we're going to take a look at the respiratory system today, okay? So we're going to break down the respiratory system, the high-yield stuff, not everything, but just the high-yield stuff, okay? So we're going to start up top and kind of work our way down based on the model that we have here in lab, okay? So what are the major structures that we're going to talk about first, okay? Talking about the respiratory tract, actually what we should do is we should bring in the other aspect to it. So where does the respiratory system begin? Can you guys tell me real quick? Let's bring another bar in here, and you guys can show me and tell me where the respiratory system begins. Where does it begin? Up top here, we've got the nose, right? We've got the nose, we've got the nares, right? Mm-hmm. The nostrils, the nares. What other components are part of this external dynamic? Do we know the bones? We've got the frontal bone. We've got the nasal bone.
The ethmoid.
We've got, well, that's internal. So external first, you're going to be correct later on. We've got the frontal bone. We've got the nasal bone. We've got this bone right here, which is the maxillary bone as well. Okay? So those are the major bones that make up the outside structure of the nose. On the inside, you mentioned the roof of the nasal cavity. That's going to be the ethmoid, right? And the ethmoid bone, we can talk about that one at the roof. And we can talk about the base. What bone makes up the base? The maxilla, specifically the hard palate. And then as we move to the posterior, what do we have? The soft palate. And it terminates in the uvula. Okay? Those are the major structures of the nose. We know that the nose has a certain type of cartilage or cartilaginous structure. What is that cartilage that we're dealing with? Hyaline cartilage, very good. Not elastic, right? And not fibro, of course, not fibrocartilage, but hyaline cartilage. All right, so do we understand the dynamics of the nose? If we go internal, on the inside view of this nose, like we said before, we understand what the roof is. Ethmoid bone. The ethmoid bone's got certain types of penetrations that allow for a nerve to pass through. Okay? Do you remember the name of the penetrations? The cribriform plate, right? And the cribriform plate is going to allow for what cranial nerve to pass through? Cranial nerve number 1, which is the olfactory nerve. So what type of mucosa do we have here? Because we've got two types of mucosa that's found in the nasal cavity. We've got olfactory epithelium, which deals with the sense of olfaction or smell. And then we have respiratory epithelium. And what does that deal with? Well, the respiratory system. What type of epithelia is this respiratory epithelium that we're talking about? At the level of the nasal cavity? Ciliated, pseudostratified, ciliated epithelium, right? With lots of goblet cells, obviously, right? Very good. We've got 3 turbinates or conchi that are found here. The superior, number 1, number 2 is the middle, and the inferior is number 3. Why do we have these? They help increase surface area to help moisten the air, help warm the air, humidify the air, right? So there's a very rich vascular network inside this nasal cavity, okay? Are we comfortable with this part here? Moving towards the back, to the posterior, I should say, of the nasal cavity, we've got a little tiny opening that's found there. If you can notate that right there, that little opening that's there. What is that opening that we're seeing there? What is that opening called? The auditory tube, right? Or the pharyngeotympanic tube. It used to be called the Eustachian tube, right? That was an old school name. Now it's called the pharyngeotympanic tube. And that's the tube that drains the middle ear, right, to the posterior, and that designates or delineates the first part of my pharynx, which is what part of the pharynx? Nasopharynx, right? Because the pharynx is divided into 3. You've got nasopharynx, you've got oropharynx, and you've got laryngopharynx. So the first segment of the pharynx is the nasopharynx, okay? And you can kind of see that demarcation by the tube that we just talked about, okay? From this area here, what type of epithelia do I have? What type of epithelia do I have in the nasopharynx? Ciliated, pseudostratified columnar epithelium. Very good, perfect. Now we move down to the oropharynx. Oropharynx is characterized because you've got certain adenoid glands that are going to help to, they're going to have an immune function to them, right? You've got your tonsils, basically, right? So here at this level, we've got tonsils. At the oropharynx, we've got food that's passing through here. So what type of epithelia do we have here? So again, this is the epithelia. It's going to be stratified squamous epithelia. Remember, the trick with epithelia is there's always 2 names to it. There's a first and last name to it. So first name tells you how many layers. last name tells you what shape. So it's either going to be one of two things. It's going to be multiple layers or one layer. So if it's multiple layers, it's stratified. If it's one layer, it's simple. So we're talking about stratified. Obviously, we don't want simple here, because what are we doing here? We're introducing things that can damage the epithelium, like food, right? You eat some tortilla chips that are pretty crunchy, you know, they can kind of damage, they can mess the back of your throat up a little bit, right? If you eat a bunch of those nacho chips. So we have to adapt for that. So what do we have there to adapt? Hot soup, right? Things like that. What do we need? We need some type of epithelia that can withstand those temperatures, those types of foods, that type of trauma in this region, and that type of epithelia is stratified squamous epithelium. Okay? Now we're moving down to the next level. We're not seeing it, not the best point of view here, but if you imagine the mid-sagittal, the next level would be the laryngopharynx. Okay? The laryngopharynx, you see basically a bifurcation where we can have the food, the air, or liquids go one of two ways. If we're talking about air, which we're focusing on this chapter, we're going to go anterior, right? We're going to talk about what structure? The trachea, right? I mean the larynx first and then the trachea later, right? If we follow the posterior, we're going to be following the esophagus, okay? So we're following the path of air, so we're going into the laryngopharynx. So what type of epithelia do I have at the level of the laryngopharynx?
Ciliated pseudostratified columnar.
Not yet. We still have
We're still at
stratified squamous epithelium. Yep, we're still at stratified squamous epithelium. We're not going to see the change until we pass those vocal cords. Once we pass those vocal cords, we're going to see a change once again to the ciliated pseudostratified columnar epithelium. Okay, so here we are at this point in time at this level. We can see from this point of view certain cartilage dynamics and certain bone. Okay, so we're going to kind of zoom in on this and pull this out here and kind of focus our attention now on this guy. Okay, so we understand that we have the hyoid bone. Hyoid bone, very important. We saw this in 201 when we saw a bunch of bones. We saw this little odd-shaped horn-looking bone. We didn't pay much attention to it, but now we know that it has significant function because it helps with breathing, it helps with phonation and support of these cartilages around this region. Okay, so this is, you know, our area of demarcation or denotation, the hyoid bone. Beneath that, below that, we've got one of our three paired or unpaired cartilages. Unpaired we have 3 and 3. We've got 3 paired, we've got 3 unpaired. We're going to focus on the big 3 unpaired cartilaginous structures because those are the most important ones. So the one that we're seeing here, this is the shield-shaped cartilage, right? Which you're seeing here, this line right in the middle, right where that number 2 is at. It's exactly where the something prominence is. What is this prominence called? What is this cartilage called? Thyroid cartilage. So this is a thyroid prominence, thyroid cartilage. We know that males and females both have this, right? It's not absent in a female, it's not present only in a male. What is different is that the prominence is more exaggerated in a male because of testosterone, and because of that, because of its dynamic, it's going to deepen the voice of the individual, yeah? So just because you have a prominence doesn't mean there's, you know, you're one or the other, right? Yes. You're basically, we all have them as humans because they're part of our respiratory system. So after this piece right here of the thyroid cartilage, we can talk about another unpaired cartilaginous structure. What's another unpaired cartilaginous structure? That's found below or beneath or inferior to the thyroid cartilage, but superior to the trachea. And we're seeing it right here as number 3. Maybe we're seeing a little sliver of it right there, number 4 right there. But this one right here, cricoid cartilage. Cricoid cartilage is right here. So that's number 2, okay? So we've got 2 unpaired structures that are really important. Again, what's beneath the cricoid cartilage is the trachea, right? The C-ring structures that we're going to take a look at later, okay? So if we take this apart, let's take a mid-sagittal view, and let's look at the internal workings of the cartilage. So if we take it apart, we look at the midline, we know this is the thyroid cartilage. We know this is the, what cartilage was this one? Cricoid cartilage. And now we're going for the last unpaired cartilage, which is a spoon-shaped structure, right? Which is the epiglottis. And what type of cartilage is the epiglottis comprised of? Elastic cartilage. Okay, it's kind of stretchy. It's going to tip over and cover the rhinoglottis to make sure that we don't aspirate. So it tips over, it closes. So when we swallow, food and liquids go to the posterior. It goes down the esophagus, and the airway is clean. there's no possibility for intrusion of these liquids or food, because if there is, what happens? We have a cough reflex that occurs, okay? So those are the big three unpaired structures. We've got three paired structures, which are the cuneiform, the corniculate, and one more, arytenoid. I think those are the other three structures that are paired, okay? Of those, the most important one to keep in mind is the arytenoid cartilage, which is found on the posterior side of things. Here they indicate it by number 5. And basically the significance of that one, the most important thing to keep in mind about that is what? It deals with phonation. The tautness or the tension of the vocal cords depends on this particular cartilage. So that's the arytenoid cartilage. That's the most important one to keep in mind. Then we have other structures, the true vocal cords or folds, and the false. Which ones come first, the true or the false?
The false.
The false vocal cords would come first, right? So if we look at this dynamic here, they're not numbered here, but they would be right above that number 12. You see that white line right there, the white line? That white line right there, those signify to us something. They are kind of avascular. So there's no vascularity to them. So, no, those are the true vocal cords. If they're avascular, that would mean that they're the true vocal cords or true vocal folds. And there's not a very rich blood supply to them. That's why when they become really inflamed, or you've got like something like laryngitis, you're going to see increased redness, erythema, inflammation of these true vocal folds. Above them, that fold above them, those are the false vocal folds. And the false vocal folds, do they play a role in phonation or sound production? No, they do not. But they do help by increasing pressure within the thoracic cavity. So you might increase pressure within the thoracic cavity or increase pressure within the abdominal cavity, right, by the closure of the false vocal cords. But the true vocal cords, they participate in actual phonation or speaking, okay? And they basically vibrate back and forth pretty harshly to create sound, okay, that we can understand. So those are the major structures to keep in mind. Are we comfortable from this point up? Now we'll kind of move. Oh, by the way, if we're talking about tissue, epithelia, we talked earlier about being in the laryngopharynx, and we had what type of epithelia? Stratified squamous epithelia. Everything now below the larynx, now we're talking about below the true vocal cords. We go back to ciliated pseudostratified columnar epithelia. Okay, so now we're ciliated pseudostratified columnar epithelia, and we're moving down to the trachea. Okay, trachea, we're seeing these C rings, right? So if we were to take this this bit out right here, you can kind of see this C-shaped dynamic, this C-shaped structure of the cartilage, of the trachea. And it's characterized by 3 layers. You've got the mucosa, right? What's the middle layer? So you've got the mucosa, the submucosa, and you've got the adventitia. Those are the 3 layers that we would see. And you also would be characterized if you see the histological cross-section of it. What else would you see? You'd see the characteristic C-ring. You see the hyaline cartilage. So it's a big giveaway that you're talking about the trachea, because no other structure has this level of cartilage to it, the C-rings, that's characteristic. So usually they'll show you the C-ring, a bit of the C-ring cartilage, hyaline, and the 3 layers of trachea. So from the out to in, it's adventitia, submucosa, where all your lymphatics and blood vessels are, and then your mucosa, where you have your ciliated columnar, pseudostratified columnar epithelium, okay, in that region. So here, trachea, it basically bifurcates at the level of the carina. The carina, if you were to look at it this way, it basically branches off into 2, where you'd have your primary and secondary bronchi, okay? So your primary, secondary bronchi will feed into your right and left lung, okay? From there, you're gonna have multiple divisions. Secondary, tertiary, quaternary divisions of bronchi to bronchioles, all the way down to what? So all the way from where we were at the nares, all the way down to what structure are we talking about? The conducting zone. What structure ends? Are we talking about where we end the conducting zone? we call that the terminal bronchial. So at the level of the terminal bronchial, on back, right, which is about, I think they're 0.5 millimeters in diameter, right? I think that's how big they get. All the way from the terminal bronchus, all the way back up to the nares, we're talking conducting zone. Is gas exchange occurring at this level? 100% no, okay? 100% no. From the blank on, we're talking about the respiratory zone. What is the blank on?
Diffusion.
No, gas exchange.
Where does gas exchange begin?
Respiratory zone.
The respiratory bronchioles. So the respiratory zone begins with the respiratory bronchioles. From the respiratory bronchioles, right, to the alveolar tree. Stay tuned. You guys are very still. Move a little bit.
Like our video.
I know our video.
Oh.
Okay, we'll keep going. Don't worry.
Oh, there you go.
Okay, edit that part
there
out.
you
So who knows how to edit? So we had the respiratory bronchioles, the alveolar tree, and the alveoli. We're all talking what? Respiratory zone. So now we're talking about gas exchange. Okay? What's gas exchange? We're going from areas of high concentration to areas of low concentration. What biochemical mechanism dictates this? Simple diffusion. Because there's different types of diffusion. We're specifically talking about simple diffusion. Okay? So the right lung, it's got 3 lobes separated by 2 fissures, right? So this is our right lung, 3 lobes, 1, 2, and 3. So you've got the transverse and the oblique fissure that gives us 3 different lobes, okay? On the left, we only have 2, right? 2 lobes, and they're separated by an oblique fissure there. So you've got 2 lobes on the left side. We're not going to get more detail than that at this point in time, okay? So from there, we talked about the respiratory, what type of, then we talk about the alveoli. We don't have a model of the alveoli, but if you imagine the alveoli to be kind of like a bunch of grapes, right? And if you ever held up a grape to the light, you can kind of see like this vascular network almost around the grape. Those would be like our respiratory capillaries. That's where gas exchange occurs. So what type of epithelia do I have at the level of the alveoli? Simple squamous epithelia. And what type of epithelia do I have in the blood vessel or capillary?
Something that turns into cuboidal.
No. The capillary itself, so we're talking about gas exchange, also has to be 1 cell thick. Because if it were any thicker, you wouldn't be able to have, so simple squamous epithelia, because if it was any thicker, you wouldn't be able to have simple diffusion. So on one side, on the alveolar side, it's simple squamous epithelia. On the other side, which is the capillary, it's what? The endothelium, right, is what? Simple squamous epithelium. So you can have diffusion of gases occurring both ways, which is a passive process, which doesn't require any energy, which is good. Going back to your question about types of cells that we have. In the alveoli, we've got about 3 types of cells that are really important to keep in mind. We've got type 1 alveolar cells, we have type 2 alveolar cells, and we have another type of cell I don't want to mention right now, okay? So what does type 1 cell mean? When we say type 1 alveolar cell, it's kind of another way of saying something we've already defined. It's the same way, not gas, well, kind of like gas exchange, but we're saying it simply means simple
diffusion.
Simple, well, what type of epithelium? So we say type 1 alveolar cells, so type 1 alveolar cells equals simple squamous epithelia. It's the same thing. And when we say type 2 alveolar cells, what does that mean? That means this is where what you were saying earlier comes in. What type of cuboidal? First name first. Simple cuboidal epithelium. And what's the significance of the simple cuboidal epithelium?
It's 1 cell thick.
Well, yeah, but what does it do? Because it doesn't really participate in gas exchange and as part of the respiratory membrane per se. It does something else.
It secretes?
What does it secrete?
Mucus?
No.
Not mucus. It secretes something that deals with alveolar surface tension. And is the reason why our alveoli stay inflated even though we exhale, the alveoli still stay inflated. They don't collapse. And if we didn't have this,
With an S.
the alveoli would collapse with every breath and we would have labored or dyspneic breathing. We would have dyspnea when we breathe. This is the this is surfactant. Surfactant. So the key about type 2 alveolar cells, which is simple cuboidal epithelia, is that it produces surfactant, which assists with surface tension of the alveoli to keep them open to prevent collapse. The third type of cell that we have there is the alveolar macrophage. And the alveolar macrophage is part of the branch of the immune system that helps clean up cell debris, foreign pathogens, particulates, all that kind of stuff. Okay? So those are the big things to keep in mind about the lab aspect of things. You would be expected to know the differences histologically about all the tissues that we've talked about. So even though we didn't see the histology of them, we did talk about them, and you should be able to distinguish one from another. Okay? For sure. And I think that basically wraps it up. Thanks so much.
Thank you.
All right.